Can you hear us now?
I think I've been talking the whole time.
Yes, now I can hear you guys.
Guys, I've been like talking to you all forever. Okay, this is fine though. This is fine. Good morning. It's big Monday vibes over here. Wow. Okay, this is fine. This is fine. This is all going on the YouTube, so this is great. Okay, so hope everybody is doing well. For those that were not with us a few weeks ago when Mac shared, Mac is a Fogarty Fellow who is doing a project in Moshi along with Liz Keating, looking particularly at transport, especially in the pediatric population, but also some in the general population. So he's going to share us a little bit about the project that's ongoing and is eager to have some feedback. So those that have suggestions, questions, comments, feel free to put those in the chat as we go through, or we'll have some time at the end to have a bit of a discussion. So without further ado, I'll turn it over to Mac. Welcome.
Hey, everybody. If I didn't meet you before, again, I'm Mac Segars. I'm in Tanzania now in Moshi. I've been here for the last 9 months. I shared some of what I'm working on last time I was doing this presentation about a month ago. Today, I want to talk specifically about a kind of subset of what I'm doing. And so I'm going to talk about pain management during ambulance transport. All right, is everybody seeing my slides? Can somebody just give me a verbal nod and let me know?
Yep. Yeah.
Awesome. Okay. And 20 minutes for presentation, 10 for feedback. Is that right?
That's perfect.
Awesome. Okay. All right. So just to get things started, looking for kind of big picture feedback. The image I have here is to remind me to tell you that I'm looking for, am I telling the story the right way? So I have all this data, and part of what I'm doing now is trying to figure out how to compartmentalize it. And so I want to worry less about like an individual variable, for example, and just say, you know, like, I think this table doesn't make sense. That's the type of feedback I'm looking for, big picture stuff. That would be perfect. An exceptionally brief intro. As far as the background, the things that you really need to know, the literature kind of divides EMS systems into formal and informal systems. The one in Tanzania is informal, and what that means is that if I get injured in a car accident, for example, then instead of calling 911 to have an ambulance come to the site of the injury with a paramedic, instead I'm responsible for getting myself to the first healthcare center, and then there can be a series of ambulance transfers from there to wherever you receive definitive care. There are no trained paramedics. Instead, there's a medical escort, which is typically a nurse, that is kind of removed from the referring site to accompany the patient to wherever the destination site is. So it's all inter-facility transport, and rather than paramedics who are trained on ambulances, you have these MEPs, medical escort personnel. And then data collection, I'm using quantitative registries anytime a medical escort arrives to KCMC and they meet different criteria, then they are enrolled, and we get a lot of information about not only the patient, the injuries, but also what happened on the ambulance. All right, these are kind of the 4 questions that I'm asking with this data. To me, it makes sense that all of this quant information would be in one paper, but maybe it's too much for one paper. Maybe I plan to have some qualitative info too. Is squeezing that in too much? Should it be a different paper? These are things that I'm hoping we can talk about. I've got the flag here at the bottom. I'm going to ask this question again at the end, so let's not discuss it now. Let's discuss it once we've kind of looked at it a bit more. These are the outcomes of interest. 1, is pain being recognized, which means essentially, are the MEPs assessing whether or not a patient's in pain? Number 2 is then analgesia availability. So do we have pain medications available on the ambulance that could then be administered to a patient in pain? Number 3, analgesia administration. Okay, so you realize that a patient is in pain. Are we then giving pain medicine to that patient? And lastly, is the appropriateness of analgesia, meaning are we giving strong medications to people in lots of pain? and weaker medications to patients in a little bit of pain, or is that not the case? So those are kind of the 4 questions that I think kind of tell the story about pain management. And again, I would love to get your feedback at the end. All right, so some assumptions and definitions just so you kind of understand where I'm coming from. So a patient in pain, I've defined this as being any patient who's on the ambulance. Again, these are all trauma patients, so they've had something painful happen. But everybody's in pain unless, first bullet you see there's NA, pain was not documented by the medical escort on the ambulance, or it was then also not documented when they arrived to the EMD. So we can't say for sure they were in pain. Maybe they had no pain. Or secondly, a patient is not considered to be in pain if we have a documented pain and that pain score is 0. So either we don't know if they're in pain or we know that they weren't in pain. Otherwise, everyone else has at least one pain score that's going to be documented greater than 0, and that patient is considered in pain. Pain level is a number 0 through 10. So we get pain levels along the care pathway. So if the medical escort assesses pain, then that is the number that I used. So if the medical escort said, the patient's in a pain level 6 out of 10. If the medical escort did not assess pain, then I then deferred to the pain score that was that the patient gave in the EMD, meaning that the MEP did not assess pain, and then presumably the patient was still in pain, and we used that pain level when they arrived to the EMD. And then lastly, pain assessment. There are lots of different ways that you can assess pain. Typically, we just ask the patient, what is your degree of pain? Give me a number 0 to 10. It's often how we ask it, like in the EMD. The only other things that are a bit different from that, I did include if the caregiver gave a report of pain. We do that in pediatrics not so infrequently. If a child is crying and say, hey, are they actually in pain? Or are they just scared, for example? And sometimes patients or parents have a lot more insight than the physician does. And then lastly, patient observation. So sometimes the MEP reported pain 6 out of 10, but it did not come directly from the patient. It was their own observation, kind of subjectively. There are standardized ways of doing this, but how frequently that is done in this setting is something that I'm hoping to dig into more in the qualitative realm. All right, so hopefully that gives some baseline info. If anyone wants to interrupt and give any feedback, especially with something that has a red flag beside it, feel free to hop in. Otherwise, I'm just going to keep going. All right, the last little bit of things to know before I get to the results. In terms of pain management, the WHO developed this analgesic ladder. This was developed for patients with chronic cancer-related pain, which is quite different than what we're talking about today. And as you can see on the left, it kind of goes from step 1, which is these kind of weaker pain meds. If it's not enough, then you go to step 2. If that's not enough, you go to step 3. This has been adapted. I got a few sources on the right here showing how this has been adapted to trauma. So there's this paper in the top right, and you can see for mild, moderate, and severe pain, they use the same kind of pain categories, or sorry, medication categories for what appropriate treatment is for those levels of pain. This one is from MSF, looks very similar. And then this one is from a paper whose goals are not so different from my own, out of Rwanda. And you can see the medications they included are quite similar too. So NSAIDs and paracetamol for mild pain, tramadol and pethidine for moderate pain, morphine, fentanyl, ketamine for severe pain. This is kind of what you see no matter where you look, with a few exceptions. And I just wanted to bring these up here because how I define these meds is actually pretty important. So this is on the top is this pain scale ladder. This was developed by a later iteration of that project in Rwanda. And you can see they've created some different categories of appropriate pain management. So you can see diclofenac, for example, which is an NSAID. Previously, in the previous slide, that'd be considered mild, but here they've included that in moderate. Morphine, you can see they've also included in moderate. And in the bottom here, this clinical protocol. This comes out of the EMD in Dar es Salaam, and they have different categories as well. Paracetamol and diclofenac considered for moderate pain, for example. So all that to say that there is no definitive standard way for saying exactly how pain should be controlled. For the sake of my own analysis, I've adopted something much more similar to what you saw on the previous slide. And this is kind of the definition that I'm using. Weak analgesics are these three up top, moderate are the two in the middle, and strong are the three at the bottom. All right, my next slides are going to be the actual results, but I'm just going to pause for a second. If anyone has any comments, feedback, please let me know. All right, I will keep going then. All right, so results. This is my table 1 and table 2. These are kind of just tables that I'm working with right now, so I am going to add in a few more variables, I think. But this table 1 on the left is the characteristics regarding the MEP, the medical escort personnel, and then the ambulance, essentially. This table 2 involves patient factors, and then essentially like the severity and types of injuries. There are a lot of different things involved in this study, the MEP, the ambulance, the patient, all these different things. So I think this is the way that it makes sense to kind of display this into two different tables. If anyone has any thoughts on that, please let me know.
Just this, I'm gonna try not to get into the weeds, but it looked like on this table, in most cases where you have unknown, the percentages that you're using are just the knowns, which I guess is a choice. It's okay, but I find it a little bit, it could be misleading, you know what I mean? Because yes, it's true that, 52% of them were male, but it's actually a little, well, we don't know. It's a range of possible. So that's just
Yeah, I
something
think
to
most of those. Yeah.
Go ahead.
All right. I think most of those are actually going to resolve just because of the way that we're collecting data. Sometimes the ambulance information comes in and then the hospital information has not been collected yet. So I think lots of these will actually go to 0 once we've kind of finished collecting data. There will probably be some unknowns, but not many.
Yeah,
that's,
sure.
That's a really good point.
Other thoughts about how it's presented? Makes sense to me.
Makes sense. On the providers themselves, do you have cadre, sex? Do you also have age?
Yeah. Oh. Just age of the patient, right? Do you have age of the MEP?
I do not think that we are collecting that. I think when I thought back initially, I can go back and double check, but I don't think I have that information. Do you think that that would be an important detail?
I mean, if you have the data there and you are able to put in, that's nice, I think.
Yeah.
But then, yeah. On the, how about on the training level? Do you? I guess you're gonna also have this on your methods, but how much education does a health attendant or clinical officer would have in terms of years? Is that a
Yeah, I think those, especially those two that Rob Beecher points out, is those aren't necessarily like universally known what's a health attendant and clinical officer. So yeah, I would hope that would just be explained in the text. Yeah.
That's good to know. Okay, yeah, I definitely did not know exactly what it meant when I got here, and now I've by force learned what all these things mean, but it's a good reminder. Okay, yeah, thanks. And yeah, this I'm gonna, for example, the ages, I'm probably gonna put some categories here. There are a few more that I'll add in here, but this is just kind of the big picture. I want to give you a feel for example, do you think having MEPs and then the ambulance in one table, and then this in another, or should it all be in one table? Or maybe it doesn't matter. Because I was actually enrolling MEPs, that's why I made them table 1.
Yeah, I think you could put them together. It's not a huge table for a paper. I mean, I think it's just a style choice. The other opinions.
Okay. I think
I
putting them
like how
together,
it's MEP factors, patient factors, health system, and injury factors. That makes sense to me.
cool.
Yeah.
All right. Awesome. Well, this is maybe so I tried to create one table that kind of answers a bunch of these questions.
Oh,
So this is, so whether or not an assessment was performed. Oh gosh, sorry. Yes or no. And you can see the majority of the time an assessment was performed, but just over 50%. Here was any form of analgesia available on the ambulance. About 60% of the time it was. And then for this column over here, any analgesia administered, this is only for patients who have pain. So I did not include a patient for what they have no pain because I wouldn't necessarily expect any analgesia to be administered. And the long story short is there were no factors, predictors that were significant other than ambulance ownership. Private ambulances were more likely to have pain meds and to administer them. So, seems that the long story short take home is, I think, that we don't perform enough assessments. We don't have analgesia available 40% of the time. And even in patients who we know are in pain, very often, only less than 10% of the time are we actually following through and then giving them that pain medicine, even when it is available on the ambulance.
wow.
So the next slides that I was going to go into kind of break down this column and this column, say like what are the analgesias that are available and how are we appropriately administering them. But I think this table is really big and kind of tells the story a lot. So before I go on, I want to see if anyone had any thoughts about this.
This is great. This table, while there's a lot, I don't think it's too much. Maybe others would disagree. I think there's like some aesthetic ways that you could do it with like colors and like bold text that would make it a little bit easier to read, but that's no big deal.
Okay.
Really interesting about how you would go about interpreting this. Like at very first blush, just having seen this for the first time, yeah, it's kind of like what you said, is even when there's people there or some resources, we're not getting enough. And to me, I kind of take this as okay, we know that like an informal transport is not going to have resources, but it turns out it seems like the even these informal transports don't have much, or sorry, the ambulances don't have much either. And even where there's staff, they don't have much. So therefore, if we're not having differences in deaths or things like that, maybe these informal systems are quote unquote working, at least compared to the ambulances that are available, which are not up to par in terms of the pain assessments, what they need. But how do you feel about interpreting the big picture? I don't know if that was comprehensible, what I just said, but
yeah, I mean, my big picture, I think, like in terms of thinking about next steps in intervention, is just from this slide. I think there will be more to add, but I think, I mean, in theory, if I am the MEP and I'm asking, do you have pain? I'm asking that because I want to know, should I then do an intervention? And more than 50% of the time we are asking, more than 50% of the time we have the med, but less than 10% of the time we then actually follow through and do the thing that we're seeking to do. So I think the qualitative will get more info into why does that gap exist. But for me, that's the biggest takeaway, is that even when we recognize there's pain, even when the medication is sitting there on the ambulance ready to be given, less than 10% of the time do we actually give it. And I have reasons why I think that might be the case, but I'm not entirely sure.
The qual will let us know. I'm also flagging a comment in the chat from Natan. The perspective as a nurse, I think, is key here. Natan says, I feel like it's missing the patient age. Usually this changes the provider's perception of pain and how they administer analgesics. That's important.
Yeah, for sure. I need to break that down into different groups. I haven't added it here, but you're totally right. Yeah, I couldn't agree more. And that will be one limitation. Very often, patients less than 5 just do not get their, like, a pain score is not assessed because they're, like, quote, pre-verbal. I don't know where 5 came from. That preceded me here. But so yeah, will unfortunately exclude several patients less than 5 years old.
Interesting. And then I see Eduardo also put a comment. Do you have info on what the pain level is when it's present? Because of course I would expect
Oh,
that to be predictive.
well, let me continue. Let me continue to the next
Please.
slide. Yeah, so
Before you
first,
move on, Meg,
Just one more thing.
but one thing I was gonna say, if you can sort or maybe group by, only show the sport variables first or the ambulance information first and then the patient, just so we can see clearly. Because like for instance, mechanism of injury is related to the patient or to the injury, but then we also have the MAP perceived injury severity. I know that they are
yeah,
linked, but maybe the order would help understand. I don't know, like ordering only patient factors and then only MAP factors,
Mhm.
okay. So
something
kind of
like
like
that.
this.
Exactly.
Yeah, but it's a suggestion. I don't. I would see people criticizing either
Yeah,
decision, like a reviewer two being nitpicky about it.
yeah. All my R code is getting pretty dense here, and so I'm having to. I think I can figure out how to do that. I could do it for this one, so I can probably do it for this one. And I agree that that's how I would like to read this table. So cool. That's a good thought. Thank you for that. I appreciate it.
Of course.
All right. And then so this is my next table. This just shows which medications are available. And long story short, diclofenac is far and away the big one. Tramadol is the only moderate analgesic that appears with any frequency. And then paracetamol. So essentially, that's what we're talking about when we talk about pain medicine: is paracetamol, diclofenac, and tramadol. Let me actually just skip ahead to the next one. So here's the strength of the analgesics given based on the pain category. So you can see that for mild, moderate, or severe pain, about 90% of the time, no analgesic was given, which is kind of exceptional to me. You assess that a patient's pain is 10 out of 10, and then don't give any pain meds. And if you look at the severe pain category, 5 patients got a weak analgesic, and none got moderate or strong. Essentially, nobody's gotten strong. Essentially nobody's gotten strong. Tramadol is given sometimes. But yeah, there's a big gap in the availability of these strong analgesic medications. I think because they're opioids and they're just very closely regulated, is my understanding of why that's the case. But the flag I have at the bottom here. One is there utility in hypothesis testing here? And what I have in mind there maybe is do like mild versus moderate versus severe. What is the distribution for each? Are these the same or different? So I can kind of conclusively, statistically say how we are treating pain is unrelated to pain severity. There's no difference between these. Is that the right outcome that I'm approaching here? Because the reason to know that would be to say, oh, wow, okay, in Kilimanjaro region, we actually really should have some sort of tiered pathway where severe pain gets this, mild pain gets that.
Makes sense to me.
Yeah. Yeah, you're gonna run into some issues with the hypothesis testing for the strong with all zeros across the board.
Yeah.
So maybe even combining moderate and strong, they're still gonna have the zero on the severe pain. But the numbers are so evident, as you're saying, that there's, of course, face validity on the none and weak.
Yeah.
So actually none comparison to the other ones.
In your previous slide, you and I think you almost referred to it. Are we explaining? I assume it's probably just one case where this ketamine was given but not available.
Yeah. I assume what happened there was that they gave the ketamine, and so therefore it was no longer available. when they went and
Oh.
like looked on the ambulance.
Hmm.
I assume that's what
Yeah.
happened there. But yeah, hard to know for sure. Big picture ketamine is almost never available. When I saw it come
Right.
across in the registry, I went, what is this?
Yeah.
So yeah, I may go back and just say like, all right, if it was given, then clearly it was available, and just like
Right.
fix that to change the numbers. But I haven't done that yet. But yeah.
Sure. Okay.
And so I think it was not included here as a strong med because
Nobody.
I think this just it's this only includes the patients with a pain score, and I'm guessing maybe in this one it was a patient without a pain score, and I still need to update that. So yeah. Anyway, sorry, I think we're getting in the weeds. But so potentially some hypothesis testing here to kind of conclusively define that we're not treating these patients differently. Sounds like people generally support that idea. And then I think this is my last slide here. So this is just copy and pasted from the previous slide. This is just different ways of showing the same data. The table to me is the one that I've landed on that I like the best. There is this other entity called the PMI score, Pain Management Index score. And essentially, you get a score based on your pain and then a score based on your treatment. But if you have severe pain, you're a -3. And then if you get a strong treatment, then they give you +3. So you want to end up at 0. That means appropriate treatment. Big negative numbers represent under treatment. Big positive numbers represent over treatment. This is what my data looks like. But the reason I dislike that is because this is essentially a function of the pain score. Since so rarely it's treated, it's almost just a distribution of pain scores. So I think it actually kind of leaves some information out. This is more useful to me in a setting where there is already a clearly defined pathway for pain treatment, which is not the case here. So you just have all these negative numbers. And then this one on the bottom right tells the same thing as the table above. It's just a bar plot. So my feeling is that the table on the top makes the most sense. But before I delete these and erase my code and everything, I wanted to see what other people think.
Hey, Mac, I have a little bit of question related to the table. You asked about doing a hypothesis test, but
Yeah.
I don't understand what's the question you're trying to answer with the hypothesis test, because I understand that you want to check if the pain category matches with the analgesic strength category, but how can I give something strong for severe pain if it's not available? So it won't give me an answer to a question because it's just not available. So I'm unable to give a strong anergetic for severe pain because it's not available. So it won't give you any further information about it. So that's what I'm asking, because I don't see a question to be answered with this hypothesis test.
Yeah. I mean, I guess you make a really good point. And I think it's a matter of, are we interested in knowing what pain medications patients are getting, regardless of the reason, because it's not available, because someone decided not to give it to them, versus what decision is being made to administer one versus another. And of course, if it's not available, you can't administer it.
Yeah. And I feel that one way to look at it would be using the appropriateness of treatments. So under treatment and over treatment would be a little bit more helpful, considering the pain category, although it goes again into the availability. And if the providers that are in the ambulance would give like morphine or any strong anergetic to severe pain in the ambulance, or would they wait until you get to the hospital because they could have like a respiratory failure or respiratory arrest? Because as a nurse, I wouldn't give something too strong, even if the pain is severe in the ambulance, if the patient is not completely assessed on how it can support or even tolerate the medicine in the ambulance. If that happens, like a respiratory failure, how would I deal with it? So that's what I'm thinking here. So I think that the appropriateness of treatment would be more insightful for you than the strength category. But I would also look at more at the availability, and looking at this, maybe some qualitative data would help to get some more insights on this one.
Yeah, for sure. That's the next step. I'm hoping we can start that very soon. So yeah, you make a compelling point. I appreciate that. But yeah, the gray boxes are the ones that I highlighted here that are the quote appropriate treatment. And so we have, for mild pain, there's only 3. For moderate pain, there's only 3. For strong, there's 0. So, and yeah, to me, it doesn't make sense to do appropriate versus not, because there is no treatment pathway. So, you know, it's not that we're doing something right or wrong per se, because there's no standard in Kilimanjaro region on you did it right or you did it wrong. Okay, so I guess for the sake of time, this is a lot of information. Does this feel like the right amount of information for one paper? I'm going to have qual data where I'm going to try to look into all of these different, kind of get qualitative information to help answer lots of these questions that we've been talking about. Would that be too much if I try to put that all into one paper? Is this already too much? What are your thoughts?
I don't think it's already too much.
For sure.
I think it's your endpoints, your outcomes all relate to one another. So I think that as of now, it's fine. But as for adding the qualitative, can you tell us more about what data you collected? Was it interviews? Was it like what method did you use?
So I have not collected it yet. We're waiting on an amendment to go through. But as far as pain, it'll be interviews with the medical escorts to get their input on essentially all of these different things, like what are the barriers to assessing pain? How are we restocking the ambulances, making sure pain medications are available? Why are sometimes people not giving pain medication even after you recognize that the patient's in pain? Things of that sort. So answering the questions that I think that we've been discussing during this conversation.
Yeah, I think it kind of depends on what the data say. Like, if you're getting kind of a cohesive story from participants and it melds well, I think it could be good to combine. If the qualitative data ends up being really complex and rich and tells a lot, maybe complementary paper would be better. You know, it also depends. It's kind of up. You have some leeway, and that'll come down to like what journal you want to use, looking at their requirements for word counts and qualitative works.
Yeah.
But so you could go either way, which is obviously why you're asking the question. Other opinions on combining or splitting?
And I don't think there's going to be so much. We're doing these interviews, and pain is only a kind of a small portion of the interview. So I don't think there's going to be an enormous amount. So yeah, I think it may end up fitting in well to it and kind of explain some of these things. So I'm leaning that way, but yeah, word counts and stuff always become an issue, I guess.
It's kind of interesting. I think it's good that you're doing it stepwise, because now this data has generated some questions for me. Like, I think you've sort of seen this, is like, you're talking about barriers to pain assessment, but I want to know, why are we assessing pain if we're not treating it? Which there are legitimate reasons. I mean, I'm guessing, they can inform the treatment upon arrival, and maybe, or, obviously not having things available is a part of why they're not treating it. But I want to know, like, why do you assess pain if you do? what's the implication of understanding the patient's pain, if not just for treating it immediately?
Yeah.
It could be interesting to see what people have to say there. I'd love to hear other opinions. Yeah. Natan put in the chat, I feel like this is a mixed methods paper. You have the quantitative data and it gives you more questions than answers. So I would follow with the qual part together. Yeah, that's a good thought, Natan. Edwin says, I agree. The why question is the most important, which the qualitative can answer. It can be one paper. So the group seems to
Cool.
lean
All right.
towards one.
Okay, that's kind of where I was leaning too. So I love it when I ask a question and people agree with me. So thanks so much, everybody.
Very good. Any other
That was
questions
it
or
for today.
comments? Oh.
Yeah, just want to say
Eduardo.
thanks for your attention and feedback. This is always really helpful.
Okay, it looks like Eduardo has some thoughts. Go ahead.
Hey, thanks. Mac, good job. I remember last time we talked, if I recall properly, most of these transports, they are actually inter-facility, right? So patient is first in a hospital and then he's being transferred to a more complex one. And my question for you, maybe that's just food for thought, but to consider, why should these patients be getting analgesics during transport if they're already in an emergency department, or if they're being assessed by a team in a hospital? And especially for those, if I recall, that are really short, some of them take like 10 or 15 minutes. So if this patient was previously assessed and medicated for pain during admission or while waiting to be transferred, should this be an actual priority for these teams who are transporting them? I was just thinking about that.
Excellent point.
I mean, if I was the medical escort and it was a 5-minute drive, I probably would not make it a priority, to be honest. Other times it's a 2.5-hour drive, in which case I think it should be a priority. But yeah, I mean, to whoever said it before, to your point, yeah, these meds can have side effects, and obviously we don't want to cause harm. But it does seem pretty clear to me from being here and from the data that we do often undertreat pain. And I mean, even I do have some data from the outside facilities too, like medications that were given at the referral centers. It's not perfect. Sometimes they just write like analgesic. They don't say what it is, but patients are in pain and they seem to not be getting the pain medicines that I would be giving in my EMD. You know, there's a lot of diclofenac given to people with severe pain. That happens over and over and over. So, yeah.
Can you confirm, Mac, is that right? What Eduardo is bringing up about the previous work, that this same data, a lot of it is inter-facility, right? It's not all pre-hospital. Is that right?
Oh, yeah, for me, correct.
Yeah, so that's huge in interpreting the data, I think. The why. Yeah.
Mm-hmm. Yeah, well, I mean, if pain medicine is on the ambulance, then I think that there is some expectation that you'd be giving it. And pain is certainly not being adequately controlled at the referral centers. So I think it depends. If it's a 5-minute trip and the patient's not in severe pain, then maybe it's not super important. But if you're coming from SAME 2.5 hours out, or the patient's in severe pain, then it seems to me like it could remain a priority.
And did I see, was it Doreen or someone else had their hand up? Anybody else want to make a final comment? Maybe not. So. Okay. If not, thanks again, Mac, and thanks to everyone for your input. Always good to collaborate on these things and get some other perspectives. So I encourage others who are working on proposals, working on projects, presentations. If you want some feedback, you can do the same. Being open to hearing some insights. So